Good afternoon, everyone. Thank you so much for joining today's webinar. My name is Kate Morales. I'm the Senior Program Director at the Hepatitis B Foundation and Director of Hep-United. We are really excited to present today's session on epidemiological tools and analytics to support the global elimination of hepatitis B. Globally today, we know an estimated 292 million people are living with chronic hepatitis B infection, yet merely 10% are diagnosed. Additionally, out of the estimated 94 million eligible for treatment, only about 4.8 million or 5% actually receive treatment. And we know these statistics due to the modeling that was created by our speaker today. So really excited to learn about the methodologies and take a deeper dive into these statistics. Before we get started, I wanted to share a little bit about Hep-United and Hepatitis B Foundation. Hep-United, we are a national coalition co-chaired by the Hepatitis B Foundation and our partner organization, APCHO. We are dedicated to addressing the public health challenge of hepatitis B, and we are currently located in 19 states and made up of over 40 national and local organizations. We are working to increase awareness, testing, vaccination, and linkage to care among high-risk communities. And a few housekeeping items to let you know how you can participate in today's webinar. You are in listen-only mode, and you'll be muted during the presentation. If there are any problems with your computer audio, the phone option is shown here on your screen with the call-in numbers. If you have any questions, please feel free to submit them during the presentation. If you think of any questions as Devin is speaking, please feel free to go ahead and submit them in the question box in your control panel. We'll be taking a look at them as they come in, and then we will answer them at the end of the webinar. And finally, today's webinar is being recorded, so you will receive a copy of the recording as well as a copy of the presentation slides after today's webinar. And now I'd like to go ahead and introduce our guest speaker today, Devin Razavi-Sher, who is the project lead, the Hepatitis B and Hepatitis Delta project lead for the Center for Disease Analysis Foundation. And he's been with the foundation since 2015. He worked with the modeling team at the foundation to develop a hepatitis B transmission and disease progression model with immigration and economic impact modules. To date, over 40,000 publications have been reviewed, leading to 121 country-specific models. Devin also leads CDA Foundation's work with the Vaccine Impact Modeling Consortium. The VIMC models the impact of vaccination for Gavi. And this work actually recently led Gavi to include the hepatitis B birth dose in their 2021 through 2025 strategy. Prior to joining the CDA Foundation, Devin was a professional research assistant at the University of Colorado Spine Center, and he has extensive experience in managing device clinical trials as well as study design and data analysis of both prospective and retrospective studies. So, Devin, really excited to have you here with us today. And I am going to turn it over to you.
Thank you so much, Kate. Thank you so much for the introduction, as well as for hosting me today and our organization to hopefully explain a little better about who we are and what we do. And I really hope that this will lead to future collaborations with some of our participants today, as that is what our organization is all about. So I'm going to get started. Oops. Quickly, just to go over the agenda. So first, I'm going to really explain who the Center for Disease Analysis Foundation is. We'll then review the process of how we work with countries and how we develop our estimates. I'll briefly describe the global work that we have done and published, as well as some of the state work we've done, which previously has really been hepatitis C, but in the coming year, we are hoping that we'll be doing hepatitis B as well. And then I will actually get into some of the details of the model, how we validated it, and part of the modules that could be of great interest to the participants. And then if we have a minute at the end, I would like to show you all part of how the interface of the model is. Sometimes it can be a little abstract from the discussion, so being able to actually show it can help. So Center for Disease Analysis Foundation is a nonprofit organization, and really what we're looking to do is help countries and as well as localities achieve 2030 hepatitis elimination targets. What we have done is we do studying, and so that's really the epidemiological research that we do that then feeds into our models, and that's part of the Polaris Observatory, where we meet with experts around the world to really understand the disease burden of hepatitis within their country, model it to help develop plans for elimination. And then more recently, we've founded the GPRO Fund, which looks to improve access to medicines, diagnostics, and use innovative financing methods to really help lower middle income countries be able to eliminate viral hepatitis. Now, we started with hepatitis C work back in 2008, and it's what we were, for the most part, most famous for, and then we started with hepatitis B in 2015. So we really provide technical assistance to organizations, ministries of health, and countries to do the hepatitis C and B disease burden modeling. As I said, we can do economic impact modeling, and we can also do model training. So we have gone to some countries and helped train them on how to use the model so that they're able to really run their own analyses and update it as the landscape could be changing quickly. Now, one of our most important things we do is we do like to publish our key findings with our collaborators, because we find that this not only can help the scenarios and proposals that we do gain more traction into actual implementation, but it also is a way to recognize the great work that our collaborators have done and all the data that they have provided us with. So to date, we've modeled hepatitis in over 100 countries, and we have over 750 country experts that we work with. This is unfortunately a slightly dated map, because we have now worked with Ukraine, Armenia, and a couple other countries that aren't on this list. So every year we seek to fill in more of these gaps wherever possible and continue collaborating and working with countries towards the elimination of viral hepatitis. Now, what we also have as part of the Polaris Observatory is we show these models that show the outputs of the models from the work we do. So we're able to show what the current, the blue line is what the current projections are based on the current treatment and diagnosis schemes, and then the green lines are what is needed to reach elimination targets. So for hepatitis B, what we're talking about is 90% of those infected to be diagnosed, 80% of those who are eligible to be on treatment, as well as we find very important the target of 0.1% or less prevalence in 5-year-olds by 2030. So how does this whole process work? What we really use is a modified Delphi process. So if you look at this figure here, what most organizations do, and most of those in academics you do, is all of the red columns. So what most people do is conduct a literature search, then they do their analysis and or modeling, and then they write a final report or publish it. What we really add is the blue columns, and we feel that this is really what gives us our strength as an organization. And so before we do the literature search, we really identify whoever the experts are in the country or region that we're looking to work with, so that we know who we can talk to get feedback on. So then we still conduct the literature search like you usually would, but then we have meetings with these experts to really review the inputs and say, you know, this is what we found, but is this truly what you see as a reflection within your practice, within your country? Here's the gaps that we found. Do you have any unpublished data? Which oftentimes countries have a plethora of data that is previously unpublished, but that they do have. And then we go back and we analyze the data, we do the modeling, and we come back to the stakeholders and these experts, and we build consensus, not only on the inputs, so not only on the epidemiological parameters, the treatment numbers, the diagnosis numbers, but we also seek to build consensus on potential scenarios. So we usually look at scenarios of what it takes to reach elimination of viral hepatitis, as well as what are current, especially when we're working in low-income countries, what are scenarios that could be feasible under the current healthcare system, as well as then if there are improvements to the healthcare system, what could happen. And after this, we draft a report that can be used by the stakeholders or the ministries of health to help push for elimination programs, as well as I said before, draft manuscripts if that's what countries want to do. So this is just a little more of the detailed about what this process looks like, where we have the pre-meeting and then we do a meeting one. Between the two meetings, we really work to gather the information that was discussed at the first meeting and incorporate it into the model, recalibrating when necessary for what has changed. And then in the second meeting, we really tie up all the loose ends and make sure that everyone's happy with what the analysis is showing, and then we develop manuscript to be submitted. Thus far, with our partners, we've published over 65 papers, and we have well over 4,500 citations and growing for our work in both hepatitis C as well as hepatitis B. So I'll briefly describe what our global work has been to date. So part of the Polaris Observatory, what we're looking at for hepatitis B epidemiology isn't only surface antigen prevalence. We're also looking at e-antigen prevalence, both among the general population, as well as among pregnant women or women of childbearing age. And we're also examining delta prevalence. Now, the model that we'll get into in much more details is a fully dynamic perinatal and horizontal transmission model with the disease burden, and we're able to add on economic impact as well as immigration. So during this literature search, what we do is we've developed a ranking scale for how representative the studies that we find are to be to the general population at the level we're looking at, which is most often national level. And so as you see, those boxes in the green are the studies that we use. So we really would prefer, of course, to use a general population that's randomly selected at the national level, with a 10 being reserved for studies such as NHANES. But we also, of course, can go all the way down to looking at large regions or multiple regions or cities, as well as with self-selected adults. Now, we do exclude blood donors from our studies, as well as any high-risk groups. And part of the reason we exclude blood donors is because often they're very rarely representative of the general population. If there's pre-screening of blood donors before they're able to give blood, then of course the prevalence is going to be lower than the general population. And if there isn't screening and it's a country with quite a bit of plague blood donors, then the prevalence could in some cases be even higher than that of the general population. And so we rank every single study that we look at and then use the most representative studies to develop our estimates. When we conducted our hepatitis B analysis, what we were able to find is data for 93% of the global population and approximately 90% of all estimated infections. So as you can see on this graph, the dark blue is the data quality that we have the highest confidence in, with the light blue, the lightest blue being that we have the least confidence in our estimates. But we're upfront about that we do have estimates for this country, but we're not as sure of these estimates as we would be for some of the other countries. So what this really resulted in is 120 country models that has now been updated to be 121 country models, and we're able to estimate a global prevalence of 292 million infections in 2016. Now, as you can see, the largest share of the hepatitis B infections in the world are in lower middle income and low income countries. Although there is a sizable portion in upper middle income countries, those in the high income countries really have a small share. As you can also see, there are some regional variations with The Americas overall at the national level having quite low prevalences, as well as much of Western Europe having low prevalence, while parts of Asia and of course sub-Saharan Africa having quite high prevalence. Now, it must also be important to mention that we've reviewed all of the data available for prophylaxis measures, and there's a huge disparity in the access to these tools. So within the WHO targets, they are looking to have all countries be at 90% birth dose, 90%, timely birth dose, and 90% pre-doses. And clearly, if we look at income levels, or even at WHO regional levels, neither of these, with the exception of WIPRO, which is mainly driven by the data reported by China, have really been met. And if there's other interventions, such as the use of immunoglobulin or antiviral treatment as prophylaxis among pregnant women, these numbers, of course, get much lower. Now, we are, of course, very happy about the fact that Gavi will be rolling out birth dose vaccination, because we really hope to see these numbers increase significantly, as they did when Gavi rolled out 3-dose vaccination in, I believe, 2001. And hopefully we'll start to see a huge change in this birth dose. However, these numbers can largely be seen reflected in the prevalence among 5-year-olds. So in 2016, we estimated there's about 1.8 million 5-year-olds who were infected with hepatitis B. Once again, the regional variations are quite similar, as we saw for the overall prevalence. However, there's a much larger share in the lower middle income and lower income countries of the prevalence, which of course, as these countries have more difficulty in accessing the prophylaxis measures and in implementing elimination strategies, it makes these targets even harder to meet. And so what this results in is we've estimated, of the countries we modeled, that at least 20 countries will not reduce their prevalence to less than 1% by 2020 and less than 0.1% by 2030 among 5-year-olds. Now, the birth dose implementation by Gavi will hopefully aid in this, but some countries do have such a high prevalence that without the use of antivirals or immunoglobulin, it will be very difficult, if not impossible, to meet the 0.1% prevalence by 2030. Now, looking at the global cascade of care in 2016, as we said, we estimated there's about 292 million infections. Of those, about 94 million are treatment eligible. Only about 28,000 of the total infected have been diagnosed, so quite a low diagnosis rate, and even fewer, only 5% of those we estimate to be eligible are currently on treatment. And once again, the lion's share of that treatment number is really coming from China. Based on these current trends, there's no way that we can meet the treatment and diagnosis guidelines for 2020, which at this point, unless countries have already implemented the change, the 2020 targets will be very difficult to meet, and 2030 itself will be very difficult unless there's large shifts in how we think about eliminating viral hepatitis and approach this problem. So now I'd like to discuss the work that we have done with US states. So in the past, we've worked with states for hepatitis C, quantifying the HCV epidemiology really at the state level, and then modeling the disease burden. What we're able to do is really show what the future burden of disease will be if no changes are made, and then do scenarios to really show the states what is needed to reach elimination by 2030 and can track their changes. So the states that we've worked with is we have directly worked with Colorado, Washington, DC, Kentucky, and Rhode Island. And then we have worked together with the CDC Foundation and the local health departments in California, Louisiana, New York, Ohio, and Washington. And we've also collaborated with ASTO in Georgia, Iowa, Maryland, New Mexico, Pennsylvania, and Tennessee. These, of course, all of these are hepatitis C analyses we have done. We have yet to work with the state to do a hepatitis B analysis, but we hope that that will be coming up in this year. So there is a new ASTRO project that we'll be collaborating with them. Unfortunately, the due date was yesterday, the January 22nd, but it will support approximately 30 states or territorial health departments. And so we'll be doing that work like we did with hepatitis C, but also hopefully with hepatitis B and C, both the burden estimates as well as elimination planning. In addition, our organization is planning a conference to really meet with other state health organizations and stakeholders to discuss elimination strategies, best practices, and lessons learned. We'll have more details about this in about a month or so. So now I'm going to get into more of the nuts and bolts of our progress model and how it works. So all of our models, both hepatitis C and B, are within Excel base because we want it to be easy to use and fully transparent. And what we have is the input data, which contains all of the data that we collect, just both background data as well as epidemiological data. And these feed into the calculations. And then we have a dashboard in which we're able to look at future strategies and create these scenarios that I've been discussing about that also feed into the calculations, which then these, of course, give us the outputs. They give us tables as well as figures that are able to show the key outputs that we're able of the model and of the exercises. So the progress model has a lot of basic inputs, and for the non-perinatal side, of course, we use all the demographic data that we use for globally. What we use is the UN population data, as well as we, of course, need background mortality, and epidemiologically, we need newly diagnosed patients, how many people are on total on antiviral treatment for hepatitis B, if the mean duration of treatment is available, that of course is helpful, and then liver transplants and how many liver transplants there are in a country, and what percentage of those are due to hepatitis B. For the perinatal, for the background data that's most important, of course, is the births by mother's age group by year, the male to female sex ratios, and then as I was discussing before, we look at the E antigen prevalence among S-positive women of childbearing age. And then what we really do is look at all the different prophylaxis measures that are available to eliminate the mother-to-child transmission. So we're able to look at the peripartum treatment, antiviral treatment of pregnant women. We look at the coverage of timely birth dose, the coverage of complete vaccination series, as well as the use of HBIG. We're also able to look at catch-up vaccination programs. So in non-infants, the percentage of certain age groups that have completed an entire vaccine series, and those all feed into the model. Now, as I said, we ran a large search to find these hepatitis B prevalence estimates for our publication, and we had over 40,000 studies identified, giving estimates for 128 countries. However, we only felt that approximately 121 of those were good enough to really develop robust models. For prophylaxis coverage, we start with the WHO UNICEF coverage rates, but we supplement this with quite a few other reports, and really the national guidelines and country interviews tend to be very important because in the reported coverage rates, there tends to be quite a bit of confusion about birth dose, where often first dose is reported as birth dose, and what we really care about is timely birth dose, so within the first 24 hours. So how the model works is for the perinatal transmission, we use the age-specific prevalence among women of childbearing age, and then that is divided into those who are E positive and E negative, and then we look at which portions of the E positive and negative population are expected to have a high or low viral load. Then we're able to implement all the prophylaxis measures to really see what the impact is. And then what's important about the model is we track anyone who's positive, but particularly tracking all female infants is important because we start to see the secondary effects of vaccination, where as those who are vaccinated as children as infants become mothers, then of course their infants will have an even lower prevalence. And we do use age-specific rate risk of developing chronic infection. For horizontal transmission, what we really do is assume that anyone under 15 is likely to be infected by both their peers as well as their caretakers, and that anyone over the age of 15 is more likely to be infected by their peers. And as I said, the risk for developing chronic infection is age dependent for these age groups. So that being said, here is the most simplified schematic of what our model does and how it works for hepatitis B. So what we have is we have the susceptible population. So infants under 1 year of age can be put into the immune category if they're successfully vaccinated, or they can be infected perinatally or horizontally and develop acute hepatitis B infection. Those over the age of 1 can become immune through catch-up vaccination, or they can be infected horizontally and develop a hepatitis B infection. Of course, some of these both will go on to be clear and they'll be recovered. So in the model, we track all of those that have chronic hepatitis B, as well as all of those that are susceptible. And this is by 1 year age cohorts and by gender. Once an individual has chronic hepatitis B, we use the following progression schematic. So they can go on to develop the later stages. We're able to treat people at any stage depending on what the country guidelines are. And then the prevalence, of course, of the chronic hepatitis B population informs the incidence, and that is, and so as you are able to reduce the prevalence, the incidence, of course, reduces as well. And these progressions are age-specific. The progression rates are age-specific, gender-specific, and we divide them by low and high viral load. So that's all fine and dandy that I've explained this whole model, but how does it actually work? What do we see its outputs in the real world? So the main objective of this model is to accurately predict the prevalence of HBsAg in the future by ages. Specifically, we really want to look at the younger ages, and especially the 5-year-olds, as that's the targets not only for the WHO, but this will most determine the future disease burden of a country. So we needed countries with comparable prevalence studies that had at least 2 time points. And for this, we found China, Iran, and the United States. These all vary by region. Their prevalences are quite different. Their E antigen prevalences are different, and they have different genotypes. Unfortunately, there were no 2 time points comparable studies in sub-Saharan Africa, but if that data becomes available, we'll of course run this analysis. And so the first analysis we did in China is we calibrated our model to the 1992 data. So what you see here is the red squares are the reported 1992 data, and the black line is what our model prevalence said the output should be for 2014, with the top blue line being the high confidence interval and the lower line being the low confidence interval. And so what you see here is we have fairly good matches for reported birth years until about 1988. And what occurs here is we're overestimating in the base, but we're still fairly well matched if we look at the low. What this really, and this continues on for all birth years, looking really at the purple squares that are the 2014 raw data that was released by China. Now, if you look at this, we were calibrating to the red dots, and 2 subsequent studies out of China in 2006, the blue square, and then in 2014, the purple diamond, I suppose, the purple diamond, both showed significantly lower prevalences in the about 1985 and 1989 age cohort. And so that really, part of this exercise shows the importance of having good input data, because we can only accurately predict future prevalence if we're using good data initially. And so we ran the analysis again. Instead of calibrating to the 1992 data, we calibrated to the 2016 data. And as you can see with this green line that's showing the 2014 model outputs by birth year, we're clearly lining up quite well with what was reported for the birth years in 2014, all the way through. When we ran it in Iran, they had done a prevalence study in 1990 prior to the beginning of vaccination, and then again in 1999 to look at the impact of vaccination. So we populated the model with the 1999 data, and these are showing the outputs, or excuse me, we populated the model with the 1990 data, and we're showing the outputs of the 1999 data. So as you can see, overall, our matches are quite good. We're within the confidence interval for most of them. We're in the confidence interval for all of them, but for the males and females, as well as overall, we're slightly lower. And as you can see, that's of course being driven by the 15 to 39 age cohort. We ran this for the United States as well. So we used the NHANES data from 1988 to 1994, and we populated the model with that data. And then we showed, so this top portion shows where we started in 1991, and then where the later studies NHANES data were. And so while NHANES shows a slight decrease, but it's relatively stable, our model was predicting a decrease. And if you look at the age and sex prevalence, we're underestimating for males, we're about right for females, and then we're overestimating for the 6 to 19 year age groups, while underestimating for 20 to 49. And overall, we're underestimating overall. Now, there's a couple points that are important to make here, which is the 6 to 19 age group, we're overestimating. When we calibrated the model, as the NHANES data is collected from 1988 to 1994, we have to pick a single year for the model. And so we picked 1991, which unfortunately was in the very early years of the era of vaccination in the United States. And thus that greatly impacted where the prevalence ended up for the 6 to 19 year olds. As if we chose a later year of 92, 93, or 94, the match is much better. It is important to note that we see this decrease for the modeled, as well as underestimating overall 20 to 49, and males having lower estimates than what was reported makes complete sense, because this model is being run without immigration being included. And those males among 20 to 49 would be those most affected, and of course it would be quite larger. It would have quite a large impact, which I will discuss next, or not next, in a few minutes. So for the economic impact module, what we see is the exact same schematic I showed before, but now we take the outputs and the calculations feed the economic impact calculations. And so we're able to put in economic impact inputs, so all the costs for healthcare, prophylaxis, treatment, and then that feeds into its own calculations that then give us EIM outputs. So the inputs that we need to run the EIM for hepatitis B is, of course, the costs of prophylaxis, the diagnostic costs, and then the healthcare costs, so those associated with inpatient care, outpatient care, and any medications that are required, excluding antiviral treatment, and then we look at antiviral treatment on its own. We then, of course, can alter these costs if there are expected to be changes in the future by time as well as by scenario. So we can look at scenarios in which there's lower costs, saying by 2023 there's lower costs, or by 2022, and what the impact will have. We're able to look at the healthcare costs that are specified by each stage of liver disease, and then all the costs, of course, can be divided into public or private healthcare systems and how much patients end up paying for co-payments. So in addition to the direct costs, we also look at health effects and economic losses. So although we are able to run QALYs. We usually use DALYs, so disability adjusted life years. They really look at the years of life loss plus the years lost due to disability. So, and this is what gives us the DALYs. So we're looking at the the health effects and economic losses of people living with the disease and not being treated for the disease. We use specific parameters that have been published by GBD as well as WHO for how much different stages of the disease impact those who are living with the disease. And economic losses are only calculated for those aged 20 to 69, as that's generally the average age for workforce. And we calculate all of these using GNI per capita of a country. So this is an example of a scenario of a country, what we ran. So as you can see, what we have here is the pink and all the other, the pink really goes over all of them, but also the red, the green and the purple. All of those are just prophylaxis increases, where the blue is the highest prophylaxis coverage. So it's the pink combined with large scale screening and treatment. And so what you're able to see is due to treating people in this country, you do see a decrease in healthcare costs, but screening costs, you have to spend quite a bit to find these people before you're finding quite a bit. But of course, the treatment and lab costs will be much higher overall. And how this translates into cost effectiveness is if you look at the direct medical costs, this ambitious scenario will, within the time frame looked at, so 2030 out to 2035, will not be cheaper than what is currently being done. But if you combine direct and indirect economic losses, by 2020, and in this chart here on the bottom left corner, so you're able to see that the cost per DALY averted by 2022, we move from between these two lines, it is known to be cost effective, and below the bottom line is highly cost effective. And so by 2022, you're able to become highly cost effective with this, which then you're able to see in the cumulative return on investment, or ROI. So I just wanted to, as I'm not going to review the economic inputs or outputs further, I wanted to show you what some of those outputs look like. So for the immigration module, this scenario is a little old because we ran it in 2016, and so we haven't updated it since then, but of course we can. So what we did is we looked at the United States and how many immigrants there were, and then what we use by country as well as by age. So this data is available from the Department of Homeland Security, and we did this at the national level. This data is available by the state level as well. And so in 2015, in the US as a whole, the largest number of immigrants came from Mexico. However, there was quite very few numbers of cases of hepatitis B because the prevalence in Mexico is low. And how we estimate this is we allocate the number of immigrants coming from these countries and the age structure, and then use all of the models we have. So as I mentioned, we have 121 country models, and for every country listed here, we have our own country model. And so what we're able to do is look at the age of immigrants and look at the number of immigrants coming from those age groups and pull how many, pull directly from that model by disease stage who could be coming over. So that's why I say it's a maximum of 40,000 additional cases of chronic hepatitis B, is because this assumes that the immigration profile is identical to the country profile. So there's no selection that, although we know that oftentimes immigrants coming are healthier than the general population in the country, this was really saying the maximum number there could be would be 40,000 individuals coming in 26, or 40,000 new cases of hepatitis B in the United States due to immigration in a single year. And what we did is we are able to look at the trends over time, and what we assume for the future is that the last year of reported data will remain relatively stable it's difficult to say if it will decrease and increase or what those numbers would look like. And so we use the last year of data to populate the model going forward. Now, what the output shows is, if you remember from when I was showing the validation, the prevalence in the US based on NHANES data shows it to be slightly decreasing but relatively stable. And this blue line shows that when we model just the United States, we see that decrease we're expecting. But when we add first generation migrants, we're able to see that the model predicts that it's relatively stable before decreasing. Now, you may be asking, why is it decreasing? And this is why it's important that we use our country level models, because in all of the countries that immigrants are coming from, there are vaccination programs. So their prevalence is changing annually and thus the prevalence of the immigrants is changing annually. And so we really need the dynamic model to be able to feed this immigration to show that, as this next slide shows, the total number of infections, as I said, the maximum number, is expected to decrease over time. And this is due to the fact that the vaccination programs are occurring in these countries. And as the older populations that have a higher prevalence really move out of the immigration age, then it will continue to decrease. But what is interesting is, based on this analysis, we found that in 2016, about 95% of, quote, new chronic cases were due to immigration. But by 2032, just based on the 2016 vaccination coverage in the US, this would reach 99% as the cases of hepatitis B in the US are expected to continue to decrease. So now I'd like to just take 2 or 3 minutes to show you the actual model, because sometimes it can be difficult to understand when I'm describing everything. So this is the dashboard. This is Armenia, which is, I traveled there in November and met with the Ministry of Health to do this analysis. And so this is what our dashboard looks like. So what we have is, in 2018, about 46,000 total infections. We know about 6,000 were diagnosed. And we have the cascade of care. We know how many were newly diagnosed, about 500 in total treated. And then, if this remains stable, what we have is wave-based assumptions. So we're able to change in 5 different waves what it looks like. And so, as I described the dashboards, we're able to see total infections are expected to decrease. Liver-related deaths will slightly increase, while new infections, of course, will decrease. And we're also able to look at the later stages. So cirrhosis will slightly increase, as well as incidence of decompensated cirrhosis and HCC will all increase before decreasing. And then what we're able to do is so we could actually create a scenario together where we click and change all of these, but I'm gonna, just for the sake of time, I'm gonna just do a pre-populated one. So now, instead of being the 500 and 100 remaining constant for all years, what we do is we increase it in each of these. And then we're able to go to the dashboard 2, if it calculates. And sorry, the model's quite large, and so it's going to be slow. And then show the impact. So by increasing treatment, so here's the total on treatment. So increasing treatment from where it was only 100 total to about 7,500, we're able to reduce liver-related deaths quite significantly, saving about 3,300 lives. Total infected is expected to slightly increase, and that's because people are living instead of dying with the disease, but they're not progressing. And of course, total infections, new infections would decrease, as well as cases of decompensated cirrhosis and HCC. And what we're able to do is also look at the impact on perinatal transmission more specifically. So we're able to look at the number of infants and how this will reduce. And we're looking at this timescale now through 2050 and how the prevalence of 5-year-olds would be. And for hepatitis B, of course, we're able to look not only at screening and treating the general population, but also what happens if we just implement stronger prophylaxis schedules. So if Armenia was to keep their pretty high vaccination coverage, and if they were just to add HBIG in a stepwise fashion, we're able to do that on this dashboard as well to show what the impact is of increasing their coverage from about 1% to almost 100%. And as I'll show in a second, this has quite a large impact on the total number of infants, as well as in the 5-year-olds. So that is the end of my presentation for now. I'd like to thank you all for your time, and I look forward to hearing your questions. And I sincerely hope that I'll get to know more of you more personally in the future, and that we're able to become collaborators and work together towards the elimination of viral hepatitis. Thank you.
Great. Thank you so much, Devin. That was really interesting and fascinating to see the modeling. So now I'm going to go to our questions slide. And I wanted to remind everyone that if you do have questions, please feel free to submit them in the question box here. And we will walk through them. And we do have a few questions that have already come through that I will read out. So our first question is, Devin, from an organization based in a nonprofit organization based in Nigeria, and I'm going to just summarize their question, but they are asking essentially how if they're interested in nonprofit organizations are interested in partnering with the CDA Foundation, how would they go about that? And they also note that there's a lot of in-house experts, including hepatologists that work within the organizations, and how would they get involved in your process? And then in particular for Nigeria, why is it so red?
No, thank you so much, and that's really important. So you can reach out to us, to organization. I know Kate's going to share our information, and working with partnering with not only ministries of health, but of course with the patient advocacy groups and nonprofits is really helpful in order to update all of our data, as well as to do this partnership. So if you reach out to us, I can put you in touch with Rick Dunn, who organizes all of the contracts and whatnot. So we do provide this work for free to, we provide scholarships for 10 countries that are lower income and lower middle income countries per year. And if you reach out to us, we can get the process started as far as that discussion. Now, as far as why Nigeria is so red, this is due to, I believe the study was from a national study that showed such a high prevalence. And I'm trying to pull it up now to see, but I can talk to you more offline as well. So it was from the national estimates and why, sorry, I'm having difficulty finding it. So it's from a national study, and that's why it's so red, is because of the prevalence being so high. As well, if I remember right, the vaccination coverage, I believe 3 doses is pretty good in Nigeria, but birth dose isn't that high. But I'd be more than happy to talk to you more offline about the specifics of what we've currently populated with for Nigeria and what we can do in the future.
Great, thank you. Our next question is, so we are very pleased about the inclusion of hepatitis B in the state work that the CDA Foundation will be doing with ASCO. Since we have little or no surveillance for chronic hepatitis B in most states, what data will you be able to use to make the hepatitis B burden estimate?
Great question. So what we can do is look at, we can really use NHANES as a starting point. So if there's specific prevalence data within the state, if the state health department has its own ideas of what the prevalence of hepatitis B is, we can use that. And if it's not, we can use NHANES as a starting point and then look at different factors within the state that could impact if that prevalence is higher or lower. So depending on various risk groups and what those proportions are in the state in comparison to the US as a whole, as well as the vaccination coverage. And so through that, we'd be able to estimate what the prevalence is, and then we're able to back calculate the estimates for what the incidence should be. Because of course, the chronic cases in a state reporting system is just the diagnosed cases. It isn't necessarily the true incidence. So even if we do have that data, it is only so helpful, if that makes sense. But we're well adept at using whatever data is available to come up with estimates that individuals feel and organizations feel most comfortable putting their name behind.
That makes sense. Thank you. Our next question is, we know that many countries won't be able to meet the targeted elimination goals for hepatitis B. We also know that many countries are developing robust elimination plans for hepatitis C. Do you have any thoughts on how we can get more countries interested and engaged in actively working towards hepatitis B elimination?
That is a great question that comes to my mind quite often because clearly of the work I do. And unfortunately, what we've found in a lot of our work is very few countries are interested in B and C. They're usually only interested in one, whether it be that they feel the cost of one or the other is prohibitive. But what we can do, I think, to really try to help stimulate this is to show, we have the tools currently to eliminate hepatitis C and hepatitis B. C, at least we have the cure, but for B, we can truly today with all the prophylaxis measures, we can eliminate mother-to-child transmission, which will then mean the future disease burden would be very low. And these interventions for eliminating mother-to-child transmission can be quite low compared to a huge screening and treatment strategy. While I think the screening and treatment strategy is important and does need to happen as well, I think that it's important to meet countries where they're at as far as what they can do and what they're willing to do. And hopefully, as people often tell me, there is a cure for Hep B in the pipeline. So hopefully things will change in the next few years and we'll be able to eliminate hepatitis B from both ends. Yeah,
we hope so. Thank you. Okay, our next question, I think this is referencing a slide that you shared related to women of childbearing age in Africa. How were you able to trace an infected child in Africa until they became women of childbearing age? It seems like it would be difficult to track.
Oh, so it's just through the model. So the model traces every single. We have population by 1-year age cohorts and by male and female. And so, as I said, the model tracks everyone who is susceptible to the disease and everyone who is infected for the disease. And so how we're able to track the infants is we know how many were infected at birth in any given year, and then that cohort ages over time in the Markov model. And of course, some of those will be infected horizontally as they grow older, but if they were successfully vaccinated, that number will of course be quite lower. And so then the model actually is populated with the prevalence data or with those. So when someone's born with it in say 2015, by 2040, if they become a mother, the prevalence in 2040 is determined by both the horizontal as well as perinatal transmission that impacted the prevalence of that age group, and then that prevalence of that individual would be there. So it's not that we're actually tracking people individually, we're tracking them at the population level within the model, if that makes sense.
Got it, thank you. Yes, thank you for the clarification. Okay, lots of great questions in the line. So their next question is, of the 20 countries that will not reduce the prevalence to less than 1% by 2020 or 0.1% by 2030 in 5-year-olds, do you know what efforts are being taken in those countries, if at all? And do those efforts involve the CDA Foundation?
So of those countries, we have worked with the Philippines, and we have worked with Kiribati, and we've worked some with Nigeria as well, I believe. I can't speak to every single one of the countries that we've worked with. I do think that a lot of these countries, almost all of them, will be greatly impacted by the fact that Gavi is implementing birth dose in 2021, and depending on what the coverage is by 2025 will of course determine what the 5-year-old prevalence is in 2030, and so I think that could have a huge impact. I know Philippines has been interested in looking at different scenarios and combating mother-to-child transmission. I know Kiribati has been interested in looking at more general population treatment, which of course, if you're screening and treating the general population, you will randomly find women who would become pregnant, and so that will decrease the prevalence in 5-year-olds as well. So we are actively trying to work with those countries if they reach out to us, and I do hope that we're able to start to see some changes.
Great, thank you. And then our next question is, I think it's from a local health department in the US. So as local health departments try to incorporate antiviral treatment of mothers into their perinatal hepatitis B case management, is there modeling specific to antiviral treatment of pregnant mothers with high viral loads alone so that we can motivate providers?
Yeah, we can absolutely do that. So the model, we can look at just keeping what the vaccination coverage is normal or currently within the local health department, and then changing nothing but slowly increasing the antiviral treatment of high viral load women who would be eligible for treatment, of course, and then seeing what that impact would have. That's absolutely one of the main things that the model was designed to do.
Great, thank you. And I'm scrolling through as we have a little bit running out of time. This question is about, I know you had mentioned using surface antigen in your modeling, and this question is specifically asking about using core antibody tests. So this is a nonprofit organization in Washington State who see clients or patients who are core antibody positive. And they noticed that this was not taken into consideration in the modeling. And is there a specific reason for that?
Certainly. So why we don't use core antibody is it just shows that someone has been previously infected, of course. And so what we need to know is how many. So when we use surface antigen, we are hoping that it's people who have been, hopefully tested twice over a 6-month period, though that data is rarely available. because that would show that they are chronically infected. So that's the assumption we make for surface antigen, is that they are not in the acute phase, that they are in the chronic phase. Whereas the core, we have used the core antibody as well as anti-HBsAg, or the antibody to surface antigen, or not surface antigen, excuse me, anti-HBs, to try to inform the susceptible population calculations within our model. However, since the advent of vaccination, it's become difficult, as often as core will only show, antibody to core will only show those who have been infected naturally, and as the anti-HBs will decrease over time for those who have been vaccinated. And so it's become quite difficult to fully find. I think the core, antibody to core, is very important to look at, when people are being infected, and you can deduce a lot of information from that. However, for the modeling, the surface antigen has proved to be the most useful for us.
Makes sense. Great. Thank you, Devin. So we are out of time, but I know that we have other questions that might have come in, and please do feel free to, we've taken note of them, and we will be sure to pass them on to Devin to get back to you. And please don't hesitate to contact us if there are any other follow-up questions that we did not have time to get to today. So Devin, I wanted to thank you so much for sharing the great work that you're doing, and we're looking forward to hearing more about the state elimination plans, as well as the global work that you all are doing at the CDA Foundation. And thank you to the audience for joining today. Please, just a quick note to please look out for a survey as you exit the session, and it would be great to get feedback so that we can continue to bring you interesting webinars and improve our webinar content. And finally, look out for a message within the next week. We will be sure to include all the materials that were shared today, as well as the recording. So thank you all again, and have a great rest of the day. Thanks, Kevin.
Thank you.